So good evening and Happy New Year to everyone, actually. Thank you for joining us today for LEJENDO. LEJENDO stands for List Endometriosis Journal Club. My name is Mikey Adamczyk. I'm a consultant endometriosis surgeon and a gynecologist. I work together with Shaheen Kazali at the Lister, and this is the team for today. For now, we've got Benedetto Mondelli, who's one of our senior fellows, Avril Baki, who is one of our past fellows, Oscar Benrick, who is going to be soon to be a fellow. We've got Shaheen Kazali, who is still in theatre today. We were operating together, and we had two lists running today. We managed to finish a little bit earlier. That's why we've joined in. So I'm going to be hosting the webinar for now. But as soon as he's done, he will join us. I know that they're doing a big case. I think they're about to finish it. They were doing a big right-sided sciatic nodule today on the sciatic nerve. So it was quite a complicated operation, but I think they're finishing, and hopefully they will join us soon. Now, a little bit of housekeeping. I'm going to be very quick. We have, as always, we will have a couple of featured articles, and we've got already Professor Ahmed Kale from Istanbul today, who's kindly joined us. He's going to be talking to us about comparison of isolated sciatic nerve and sacral nerve with endometriosis, which would be a review of literature. And we also have Professor Oliver Donners from Leuven, who is going to be talking about conservative management of rectovaginal endometriosis. And this webinar will have a good mix of professionals, of surgeons, but also we will have patients advocates on it joining. So let's keep everything as light as possible. And Shaheen is here. Hi, Shaheen. You've managed? Yeah, it looks like he's just setting up. So I think, can you hear us? You're muted. Yeah. So while Shaheen is setting up, I think what we can do is, Avril, start with your first paper.
Yes, let me share my screen. Are you able to see my screen?
Yes.
Do you see the presenter kind of slide or like the main?
We see a presenter slide.
Okay. Fine. Let me take this.
While we're waiting on Avril, I just want to also thank Carl Stotz for helping us to sort those.
Okay, shall I start, Mikey?
Yes, please, go on.
All right, so the first paper I'm going to present on is a paper by Professor Roman, which is very unique and one of a kind, looking at the long-term risk of repeated surgeries. So this is a retrospective study based on a prospective database collection, which included all women with histologically confirmed endometriosis and first surgery performed by Professor Horace Roman. These patients were given questionnaires and were followed up at year 1, 3, 5, 7, and 10 with questionnaires which they had to fill up and explaining whether or not they've had repeat surgery. Well, exclusion criteria in this study were non-French and non-English speaking patients because these patients were not able to answer the questionnaire, patients who have had previous surgery performed by another surgeon, and those with repeated surgery already enrolled in the Serendo database. So on the left here is the baseline characteristics of the patient with surgeries with the first surgery. As you can see, 98.2%, most of it performed in the minimal access route. More than 50% had endometriosis affecting the bowel, requiring either shave, disc, or colorectal resection. So out of 1158 patients, 65 were excluded because they did not complete the questionnaire or the follow-up. So in total, we had 192 patients included in the study. And in total, at the end of the 10-year follow-up, 155 patients underwent 174 repeated surgery related to endometriosis. As you can see on the right here, in the first year, 3.4% of patients had a new surgery, as in 36 new surgeries were performed. And then at the 3-year, a further 69, 7.4%. At the 5-year, a further 45. At the 7-year, a further 20 surgeries. And at 10 years, 4 further new surgeries were performed. So this table looks at the indications for the repeat surgery that was performed. And as you can see, most of them were due to relapse or pain symptoms, about 9.9%. And the second most common indication was surgeries for infertility management.
Yeah, go on, Avril.
Should I proceed? Yes. And the second most common cause was due to infertility, about 3.6%. Hysterectomy was the most common surgery that was performed, about 4.1%, followed by salpingectomy for hydrosalpinx, 2.4%, and then a repeat bowel procedure, which is 1.3%. This next slide looks at the type of surgery performed in the first surgery, and then compared against the indication for the second surgery. And what was very interesting is, so in the group where they only had superficial endometriosis found in the first surgery, 13% had to have repeat surgery for pain recurrence. In those who had deep endometriosis sparing the bowel, 12.7% had to have repeat surgery for pain recurrence. And this is about 3 times more than the group that had only endometrioma or had bowel endometriosis. And in terms of the group with bowel endometriosis, the most common indication for repeat surgery was infertility. This was the highest compared to the other group. This is a multivariate model which looks at the predictive, independent predictors for reduction in the probability of having a repeat surgery. And the author found that having a post-operative pregnancy and a hysterectomy were statistically significant independent predictors. So what does this mean? So in conclusion, up to 28% of patients may require repeat surgery during the 10-year period after the first surgery. In other words, 3 out of 4 women may not need to have repeat surgeries for up to 10 years if the first surgery was an excision of all visible macroscopic lesions performed by an experienced surgeon. Performing a hysterectomy in the first surgery was also found to be independently associated with absence of repeat surgery. So this is something that can be discussed in association with complete excision with the patient to reduce the likelihood of repeated surgery. And that's all from me.
That's a very interesting paper, Avril. I'm sure everyone has seen it and read it. I certainly did, but I can't remember. Do you remember for the group that had uterine sparing surgery? What do you remember? How many of them had adenomyosis?
No, so this was actually one of the limitations of the study. They said that they did not have data on histologically proven adenomyosis, actually.
Okay, because that's something that patients always ask us in clinic, and I'm pretty sure Shaheen and Ahmed and Professor Ustad, that's something that you get a lot in your clinic. What is the percentage of me having a reoperation? What do you tell your patients? Ahmed, for example.
The reoperation of the deep endometriosis surgery during 5 years, I think I say that 20% during the 5 years. 20% of the patients might have a second operation during 5 years, and I think this is related to 28%. I think in this literature.
Yeah.
But I think another explanation is that the evaluation, the first evaluation of the patient is some limitations. For example, some surgeons in Turkey, especially, just making a surgery before very well evaluation. So during the surgery, there are some, for example, rectal nodules or sacroiliac nodules is left in situ in the patient. So this incomplete surgeries can also result second or third surgeries. So preoperative evaluation is, I think, mandatory as surgery as so. I think it is one of the important thing is preoperative evaluation, and also mapping is important after mapping, and multidisciplinary team is also another important issue. Not just a gynecologist, maybe a urologist, and also sometimes colorectal surgeon is also should be experienced about the surgery, whether they will make a segmental resection, discoid, or shaving. I think these all are the important issues to decrease the recurrence rates, I think.
I absolutely agree with it, especially with the preoperative mapping, 100%. Shaheen, do you want to add anything, or should we move on to the next paper?
Yes, please move on. I'm sorry that I'm late. I'm still in the operating room. We're still closing, so you carry on.
Don't worry, take your time.
Yes, yes, thank you very much.
Oscar, you next.
Yeah, brilliant. Thank you. And thanks, Mr. Ghazali and Mikey, for the opportunity to present today. So the first paper that I'll be presenting is a prospective study on bladder function following endometriosis surgery with an 8-year follow-up in Sydney, Australia. That's lovely. Thank you. So objectives were to assess the long-term urinary function of women having laparoscopic surgery for endometriosis. And this was a nested cohort study within a much larger RCT that aimed at assessing urinary function following any benign laparoscopy for gynecological presentations. And it was across 2 tertiary level university-affiliated hospitals in Australia. So in terms of the results, they had 711 patients and 518 of those were diagnosed histologically with endometriosis. 55% of those consented to the nested study, and at a mean of 50 months post-operative follow-up with quite a drastic range between 12 and 103 months. There were 35 participants, so 12%, with bladder symptoms that required treatment, and 28% reported at least one urinary tract infection since their index surgery. There was a significant worsening of symptoms in all domains of filling, voiding, incontinence, and quality of life between the preoperative questionnaires and the postoperative questionnaires. So on the right-hand side, you'll see 2 tables. Bear in mind, a high score is a bad thing. So you can see in all domains, the scores increase. They did, however, find that there was no statistically significant difference in urinary questionnaire scores between participants with and without uterovesical endometriosis in particular, which is actually quite interesting, and that there was no difference in any parameter when comparing the different stages from the RASM endometriosis scores. That's the graph on the right-hand side at the bottom. So you can see that actually the severity of disease does not seem to impact the urinary function postoperatively. Next slide, thank you. So the key points, obviously, I'm sure most of you here know the inferior hypogastric nerve carries the nerve fibers responsible for bladder detrusor muscle contraction and relaxation, and also the urethral sphincter contraction. And damage during the surgical resection of endometriosis is thought to be what's causing the urinary dysfunction in these ladies. This study suggests that there's a general decline in urinary function over time following laparoscopic surgery for endometriosis, but that this decline does not appear to be dependent on the severity or even the location of the disease.
Right. Thank you, Oscar. Another really interesting paper, and I personally do discuss urinary function for my endometriosis patients, and I'll be interested to hear what Ahmed, for example, you do with your patients, especially when you have deep parametrial disease or some of the neuropalbiology patients that you operate on. Do you discuss urinary function in details? Do you teach them how to self-catheterize just in case they need to do that postoperatively? What is your approach to that? I think you muted, Ahmed.
Yes, I really discuss all the details and consequences and complications of the surgery, especially parametrial endometriosis. As you know that in parametrial endometriosis, there might be a infiltration of pelvic symplectic nerves, and also after the surgery, there might be mostly the transient urinary dysfunction can occur, but sometimes it might be a permanent dysfunction can occur. So this is very important, especially in bilateral cases, bilateral parametrial endometriosis. This risk is very higher than expected. So the severity of the location, I think the location is very important, especially the infiltration of the pelvic symplectic nerves. I suggest that if possible, during the excision, maybe intraoperative monitorization is the utmost important. For example, we are performing intraoperative monitoring, especially in pelvic nerve surgery during sciatic decompression or pudendal nerve surgeries. That's because there may be a permanent dysfunction of the extremities. It is valid also for the bladders. And also with this intraoperative monitoring, the intra-urethral catheterization and urethral electrode and rectal electrodes maybe is important while performing these surgeries, and you can monitor at the same time during surgery. So it should be, or it must be discussed before the surgery with the patient.
Brilliant. There's a good question from Sandesh Kader. What is the role of preoperative urodynamic study? Do you send your patients with deep endometriosis of the parametria for urodynamics? Is that something that your group does?
I don't routinely send the patients to the preoperative urodynamic evaluation. I don't routinely do, but especially in bilateral parametrial endometriosis, yes, I send the patients to the urodynamic evaluation, and also after the surgery, I really follow up these patients with urodynamic evaluation. But in unilateral cases, I don't really routinely send the patients to the urodynamic evaluation.
So that's a very similar approach to what we do. Okay, I think we can move to you, Ahmet. So we've got Professor Ahmet Kalev from Istanbul. Thank you for joining us. And I think you've got your colleague, Professor Taner Usta, that might be joining you for the discussion, I believe. And you're going to be speaking about comparison of isolated sciatic nerve and sacral nerve roots endometriosis review of literature. And I'm really looking forward to hearing this.
And can I just thank you as well, both Ahmet and Tanesh. Can you hear me?
Yes.
Yes.
Shine, hi. This is Taner.
Yes.
Thank you so much for the invitation.
No, I'm very grateful. I'm really grateful for you joining us. And I'm sorry that I wasn't there from the beginning, but Mikey's doing a better job than I would do. So you're in good hands. Yeah, this is an interesting topic. We just did, or maybe I will share with you.
Go for it.
Anyway.
I share it with you. Do you see?
Yes.
Okay.
Yes. But do you want me to share something? Let me share something. Okay, doesn't matter. I'll share later. But yeah, we just finished.
Big module, show it, Shaheen. Yes.
Huge. Yes, but make me host so that I can.
Avril, do you mind changing the host for a second?
Do I go on?
Yeah, that's good.
Yeah, Mr. Kazali, your host now.
Okay. So, no, don't worry, I can't do it. No, you carry on, because to share, I need to actually show the pictures. Doesn't matter. I'll take pictures and I will share it with you later.
Okay.
So just to maybe explain that I've told.
Yes. So we just finished operating on a lady who's a physiotherapist herself, and had very typical sciatic endo symptoms, and MRI showed this massive nodule, 4.5 centimeters, in the right parametrium, encapsulating the internal iliac vein, artery. But when we went in, it was even worse than that. It was involving the ureter, causing stricture to the ureter, and also involving the external iliac vein. So we made a hole in the external iliac vein, but in the end, we managed to remove all the disease. It was quite difficult, but very interesting. So I'm really hoping that she will see big improvements.
Okay. Do I go?
Yes, yes, go.
Okay. First of all, I really thank to Dr. Shihan Kazali for his nice invitation to this Lister Endometriosis Journal Club. We published the article in JUMIC at 2022, and we compared the isolated sciatic nerve and sacral nerve root endometriosis and reviewed the literature. As you know, that
Kali, do you mind sharing again your presentation with us?
Is there any problem?
Yes, we can't see your slides. Do you mind trying again?
Okay.
That's perfect. Yeah.
Okay. Okay, do you see? There's
Yes,
no problem.
perfect. Thank you.
As you know, that endometriosis is a common gynecologic disease and is located outside the uterine cavity endometrial glands and localized in ovaries, gastrointestinal tract, chest, urinary tract, as it is known, and affects approximately 10% of the reproductive age women. Is isolated sciatic nerve and sacral nerve root endometriosis are extremely rare conditions, and underlying mechanisms have not yet elucidated. As is a normal, there are lots of theories: perineal stress, retrograde menstruation, hematogenous, and lymphogenous spread. But these theories doesn't really explain the isolated sciatic nerve endometriosis. So evaluation of anatomic distribution of the endometriotic lesion may cast light on the pathogenesis of the. To date, there are little published data on endometriosis involving isolated sciatic nerve and sacral nerve root endometriosis, and which are mostly consist of case reports. For this reason, we compiled and analyzed the available data. Our objective is the anatomic distribution, patient symptoms, history, diagnostics, treatments, and outcomes of the isolated sciatic nerve endometriosis and sacral nerve root endometriosis. If you define the isolated sciatic nerve endometriosis, it is involving the sciatic nerve. It is not a part of deep infiltrating endometriosis. If you define sacral nerve root endometriosis, endometriosis infiltrating sacral nerve root endometriosis, and as a part of parametric DA, we searched PubMed, Medline, Web of Science, and Base from inception to October 2021. And we have keywords: sciatic nerve endometriosis, sacral nerve root endometriosis, and associated medical headings. We included original research articles, case reports, case series, review articles for analysis. We also performed statistical analysis, and K-square test and shared square exact test was used for the study. And also after the analysis, we find 92 articles, but 8 articles in non-English language were excluded. A further 10 were excluded because of unavailability of their full text. And briefly, a total of 40 articles and 362 patients were included in this review. And 256 patients in the sacral group and 110 patients in the isolated sciatic groups were included in the study. And mean age, or both of the patients, approximately 30 years of age. Dysmenorrhea, deep dyspareunia, constipation, and dyschezia were more frequently observed symptoms in the sacral nerve endometriosis group than in the sciatic group. Hydronephrosis was observed more frequently in the sacral group than in the sciatic group. Preoperative GnRH analog was more commonly used treatment in the sciatic group. Sciatic pain and sitting pain were significantly higher in the isolated sciatic nerve endometriosis. If you look at the physical examination, foot drop was observed more significantly in the sciatic group, although pudendal neuralgia were significantly more frequently seen in the sacral endometriosis group. If you look at the urodynamic evaluation, urinary urgency and frequency commonly observed in the sacral group. In contrast, there were no cases in the sciatic group. MRI was used as a diagnostic modality in both of the groups, both isolated sciatic nerve endometriosis and sacral nerve root endometriosis. If you look at the concomitant surgical procedures, segmental colorectal resection, ureterolysis, adhesiolysis, and colpectomy were performed in sacral group. but there were no cases of the sciatic group. These surgeries were performed. There is no difference between the intraoperative and postoperative complication between these two groups. If you look at the results, as for laterality in both groups, most patients had right-sided endometriosis. L5 to S1 root infiltration was observed more common in the sciatic group. S2 to S4 was observed more common in the sacral group. The most common EMG finding was sciatic nerve damage, followed by peroneal nerve damage, peroneal and tibial nerve damage. In the sciatic group, 10% of the patients received transgluteal surgery, whereas in the sacral group, the most common surgical procedure was laparoscopy. The postoperative surgical treatment failure was significantly higher in the sciatic group. The most common postoperative surgical treatment failure is the foot drop in the sciatic group. If we discuss, sigmoid column protects the left side inguinal canal, sacral roots, and sciatic nerves from endometriosis. Because of this region, isolated sciatic and sacral nerve root endometriosis were common on the right side than on the left side. Endometriosis involving the sacral nerve roots is a part of parametric DA and have close anatomic relationships with sacroiliac ligament, cardinal ligaments, ovarian fossa for S2 to S4 involvement. Isolated sciatic nerve endometriosis is not a part of parametric DA and located at the suprapiriform portion of the sciatic nerve. Isolated sciatic endometriosis usually affects the L5 to S4 nerves, whether the sacral nerve root endometriosis affects sacral 2 to sacral 4 nerves. Sciatic pain is the most clinically relevant finding in isolated sciatic nerve cases, whereas sensory-urinary urgency and motor bladder hyperactivity were commonly observed in the sacral group. Deep dyspareunia, cycle-related gastrointestinal complaint, urinary urgency, bladder hyperactivity, and pudendal neuralgia were frequently observed in the sacral group. Although problems in locomotion systems such as foot drop and sciatic pain were more frequently observed in the sciatic group. Isolated sciatic nerve endometriosis begins with cyclic sciatica and becomes constant over time. Some patients in the sciatic group received transgluteal surgery because of transgluteal approach has been historically referenced by a large number of neurosurgeons. However, the transgluteal approach allows the surgeon to access the infrapiriform area, but not the course of the sciatic nerve within the pelvis. GnRH therapy could be used for both of them. MRI is the main imaging model for both groups. EMG may be a useful tool in absence of instrumental or radiologic evidence, and it helps to differentiate differential root and peripheral nerve involvement. There was usually no significant improvement after surgery in cases of isolated sciatic nerve endometriosis presenting with foot drop. If medical therapy fails, surgical treatment is planned as soon as possible, given that the patients are exposed to permanent disability in the event of gait disturbances and foot drop. Conclusion, isolated sciatic and sacral nerve endometriosis are more common on the right side. Laparoscopic surgery is more commonly performed over traditional open or transgluteal surgery. Sacral nerve root endometriosis is often accompanied by deep infiltrating endometriosis. MRI is a useful diagnostic tool for both of the groups. There was usually no significant improvement after surgery in cases of isolated sciatic nerve endometriosis presenting with foot drops. And lastly, we are inviting you our meeting that will be held on the 2nd and 3rd of February 2024. And in collaboration with the Oxford and Edinburgh University, we will discuss endometriosis and adenomyosis from bench to bedside. And this will cover only the pathophysiology and basic science of the endometriosis and adenomyosis. Thanks.
Brilliant. Thank you very much, Professor Kalle. Do we, maybe to start with, do we have any questions from the audience? Let's have a look. Just to confirm the disease for the surgery. So no specific questions in terms of your presentation just yet. I've got a question because I always find it very interesting, and I'm wondering What's your take on it? What is the pathophysiology of the disease? And what do you think it is? Because for the number of sciatic endometriosis cases that I've seen, most of them, as you said, were on the right-hand side. Why do you think that is? Do you have any explanations for it? And Shaheen,
Yeah. To me or to Shaheen?
to you to start with, and then maybe Shaheen can chip in.
Okay, there's a published literature from the Vercellini. As we know that most of the endometriosis is seen and pelvic endometriosis in left side, but this both of them, sciatic and sacral nerve root endometriosis, is located at the right side. That's because there's a pathophysiology that Vercellini explaining that there are pockets in the pelvic peritoneum, as you know, that these pockets, some endometrial cells is collected in these pockets, but in the left side there's a sigmoid colon, and these pockets makes a channel between the sciatic or pudendal sciatic nerves or sacral nerve roots, but the sigmoid colons interfere with this channel, so protects or prevents accumulating this endometrial cell to the left side. Because of these reasons, sacral and sciatic nerve root endometriosis is commonly seen in the right side, but this is an explanation of Vercellini, but this is an, I think, plausible and logical explanation that why the isolated sciatic and sacral nerve root endometriosis is located on the right side.
Okay, interesting. I didn't know that actually. Shaheen, do you want to add anything?
I don't think we know, to be honest with you. If we buy that explanation, then we should have seen more pocket formation on the right as well. We should have seen more uterosacral disease on the right as well. I don't know. I don't think anybody knows. The patient we just did was also the right side. And one thing that I wanted to ask both Ahmed and Tanesh is that I have now seen 3 patients in a row with the confirmed sciatic nerve endometriosis. And in all 3, the pain onset was very sudden. So not the usual, first it becomes cyclical and then carries on and gets worse and worse and worse. And then, no, all 3 of them, well, one of them was an athlete, and this happened after doing an athletic event. Today's patient was also she's a physiotherapist, and she was doing a squatting challenge. And the third one was right after a urological procedure where I think they just overextended her legs. I want to ask if you have seen that as well, if this is something that you've experienced as well.
I have no experience about the acute onset of the pain is not a usual sign for sciatic nerve endometriosis, as it is known that the sciatic nerve endometriosis begins with pain begins with the menstrual cycles, and when the time passes, it becomes constant and intense, and severe pain can occur. But I have no patient like this.
Yeah.
Pain is constant.
Very
intense
interesting.
time. Yes, very interesting.
Because in all 3 of them, when I saw all 3 of them, I said to them that, look, this pain is not typical for sciatic nerve endometriosis. Sciatic nerve endometriosis doesn't have an acute onset.
Yes.
So I think it is unlikely. And then we did an MRI, all 3 confirmed, you know.
In the sciatic.
Yes, including today's patient.
Is there any location, the different location, for example, the sciatic nerve endometriosis is mostly infrapiriformis, suprapiriformis level?
No, suprapiriformis. So all 3 of them have been in the obturator internus muscle.
Yes, it is an unusual presentation, I think. It doesn't begin.
So maybe we should publish the series, because these all 3 of them are very different to what we expect to see.
Do you have any idea why they might begin as the acute onset? Do you have an idea?
We were talking about it, and this is a very unlikely explanation. But I just wonder whether it starts with a traumatic hematoma within the muscle, and this goes on and on and on. And then maybe there is some menstrual blood there, there is inflammation, there is tissue implantation in that area. But I can't explain it. But all I can say is that all three of them in a row, actually, after an unusual physical examination, physical exercise. One was a squatting competition. So do you know what squatting is? You know, sitting down. So she was doing a competition in Australia for squatting. So she did that, and then immediately after that, okay. When she came to see me, I said, look, this is a musculoskeletal problem. There's no question about that. It is muscular. And then,
does the patient have any other physical abnormality like a gluteal atrophy or like this?
No, she doesn't. Yeah, she doesn't have gluteal atrophy. But you know, clearly today we operated. Clearly was endometriosis. There's no question about that. You know, chocolate material coming out, and all that area was completely stuck, and the ureteric stricture due to this was the biggest endometriotic nodule in the sciatic nerve that I've ever seen or heard. I don't know what size you've seen, but this one was taking the whole of the iliac vessels on the right side. The chocolate material that was coming out of it was just kept coming, didn't it? It was like a, I don't know, 6 centimeter endometrioma. How much chocolate you see from that? That's how much chocolate we got out of the sciatic nerve and the obturator internus muscle. It was very interesting.
Yes.
Hey, Shine, I would like to share my experience about the sciatic nerve endometriosis. Normal, the typical approach is not like that one. You know, these are very weird case, but sometimes we see very weird case in a clinical practice, by the way. So normally they have a very chronic pain, but sometimes that symptoms are exacerbate. They have a much more symptoms, but they have a very chronic symptoms. And so the clinical symptoms are very typical. They have a very chronic, very severe pain. You can make a diagnosis when you see the patient, not only the touch or make an MRI. When you see the patient, when you see they are walking or when they are sitting on the chair, you can easily diagnose, yes, that lady have a sciatic nerve endometriosis. But sometimes we see a different case, especially in sacral nerve endometriosis. In some case, in sacral nerve endometriosis, there were some symptoms about the bladder, but some of them, they haven't had any symptoms about the bladder. So we cannot
I think
say
today's
that
patient also didn't have any symptom, any bladder symptoms, did she? No bladder symptoms.
Normally, yes, we have to exclude some problem about the bladder, but this is not only one rule. They have the same symptoms or they have the same problems at the same time. But the main problem is we have a very rare case. It is not a bad point, I have to say that, because in some cases it's not easy because they have a very large nodule on the sciatic nerve and the surrounding tissues. And so the surgery, we know that we face a lot of problem during the surgery. You mentioned about one case, that lady have some problem on the vessels. During the surgery, you have to solve the problem about the ureter. You have to solve about problem about the vessels, not only the nerve. Nerve is sometimes some colleagues think that it is very difficult issue, but if you know some structures, it is easy way perform the surgery. The most important point, Ahmet underlined that one, diagnosis. Before the surgery, you have to show something, but I
yes. Carry on. I will show you in a second.
Ahmet underlined that topic. Diagnosis is important. So you have to know full conditions. Mikey explained this ask us some question about the recurrence, but we know that, especially everybody showed us a very good information about the recurrence rate. But we have to open the discussion about what is the problem about the endometriosis surgery. The problem is the endometriosis surgery recurrence or incomplete surgery about that case. In endometrioma, deep endometriosis on the rectum, deep endometriosis on the sciatic nerve or the sacral nerve. What is the problem about that one? The recurrence of the disease, or these are related with the incomplete surgery or incomplete diagnosis of that case?
Yes, and I think you're absolutely right that the thing that causes the most problem is really incomplete surgery, and incomplete and wrong surgery is another one. That you think you've done the complete surgery, but actually it was the wrong diagnosis, and you didn't need to do the surgery in that way. So yeah, let me show you some pictures from today's case. She also had quite bad endometriosis. This is after the hysterectomy, and you can see a full thickness vaginal nodule. So this is inside the vagina, yes. And this is the, and it was also an interesting one because usually we see the full thickness vaginal nodules right behind the cervix, don't we? We just see it coming from the torus internus. This had probably a 1 centimeter gap between the cervix and the nodule. But anyway, that's that. Here you see, yes. So this is the internal iliac artery. And you see that's the disease, that's the epicenter of the disease. And this is completely infiltrating the internal iliac artery and vein.
Did you put a graft? Did you put a graft for internal iliac artery or
no? We just removed it. Yes,
removed,
no,
okay.
No. We have
infiltration is superficial or deep infiltration?
Yeah. It is deep infiltration.
Yes.
But yes, with the internal iliac vessels, there is no problem in getting, in obstetrics, we do that in obstetric massive hemorrhage bilaterally, and we get away with it. And, they can even go get pregnant. In unilateral removal of internal iliac is not a problem at all. So this one was also interesting. Let me show you.
Ali, did you have
yes.
to sacrifice the whole nerve, or did you shave it off the sciatic nerve?
No. I shaved it off. No, I didn't sacrifice the nerve. Yeah, but maybe we can discuss this. Maybe Ahmed and Tanesh will be able to give us their overview. Look at that. This is, so much brown material came out of this area of the nerve. This is on the right side, obviously. And then this is almost the end result. So you see that's the sciatic nerve, and you can see the lumbosacral trunk, and then you see S3 and S4 going there. You still see some nodule there that was removed completely. So what I want to ask you is, we were very worried and we were very careful not to cut any of the sacral nerve roots. What are the consequences of cutting, let's say, S2 or S3 on one side?
A very good question, Shaheen.
Ahmed, do you want to go first?
Yes, my idea is that if you, it depends on the severity of the resecting of the sacral 2 and sacral 3. If you completely resect both of the sacral nerve roots, I think there might be a foot drop, permanent foot drop, and also there might be a gait disturbances after the surgery. And also there's an, as you know, that sciatic nerve function, hip abduction, and also extension of the knee can maybe distracted if you cut sacral 2 and sacral 3. So I think, in my opinion, using an intraoperative monitoring is much more beneficial, because extensive surgery, especially and distracting all of the nerves, sacral 2 and sacral 3, might really give patient to a permanent damage. But if you only shave the sacral nerve roots or sciatic nerves, if you don't transect the sciatic nerve completely, and as you know, that there is also published literature from the Passover, if you resect more than 30% of the sciatic nerve, but if there is an integrity of the sciatic nerve, it may recover, axonal recovery can occur, even if you resect more than 30% of the sciatic nerves. But the postoperative physiotherapy is essential. But cutting all of the sacral 2 and 3 is really, I think, dangerous. You can put the patient to, I think, a dangerous situations. So we published a literature about intraoperative monitoring, not a long technique, and we are putting electrocatheter tibialis anterior muscles, gastrocnemius muscles, and also abductor hallucis muscles and external anal sphincters to monitoring the sacral nervus and sciatic nerves, whether during the operation, because after the operation, if there is a permanent damage, it will be very disappointing results for us and for the patients. It's my opinion.
Shine, I remember the Benoit Rabichon presentation. Maybe you remember that. Benoit, our president, always share one slides. If I cut that nerve, what will happen? You know that slide. Nothing happened. Yes. Normally, nothing happened. By the way, the answer is that one. But this is not a good message for the participants. Normally, yes, we have to always preserve the nerves, but the human nature is unbelievable, by the way. Sometimes we say that when we cut that structures, we face a very big problem. But the main problem is the disease make infiltration on that nerve. When you cut that, some necrotic disease, some necrotic tissues, or unfunctional tissues, you would not expect much more problem after the surgery. The main problem is, if you don't know that is the normal structure or that is the affected structure, which is infiltrated by the endometriosis, that is the problem. You don't know that structures, and then you make a very big dissection. You make a very big cutting that structures, then you can face a problem. But the main question is, sometimes I have to ask that one, do we really need to cut all that lesions in the surgery? Before that surgery, can we add some medical treatments and make some shrinkage of that lesions before the surgery? Maybe we can apply the surgery after that one. This is another question about this topic.
I want to add some comments about Dr. Taner's, if we have a time. If you look at the literatures about the sciatic and sacral nerve roots endometriosis, there are some case reports that they gave a GnRH therapy to decrease the size of the endometriosis lesions inside the sciatic nerve or sacral nerve roots. But when you stop the therapy, you cannot give in a long term, as you know, that there are some side effects. And if you stop this GnRH therapy, it will recur, and also the pain constantly and intensively is permanent, and there are some foot drops or some gait disturbances can occur under this therapy. So I think this therapy is transient, and you cannot use for a prolonged time. Maybe if the patient is a is at the perimenopausal age, maybe you can use, but the mean age of these patients is 30 years of age, is very young patients. They are suffering this, suffering the sciatic or sacral pain. So I think this therapy doesn't work in a long term. It is my opinion.
Okay, guys, I have to go. Thank you very much again. I will catch up with you later. Bye bye.
Okay, bye, Shaheen. Right, really interesting conversation. Thank you both for speaking to us about it today. I guess maybe last question for both of you before we move on. I know we're running slightly behind. But what is your experience with reoperations of sacral nerve roots? Is that something that you've done? Is that something that you've seen quite a lot? And how do you go about it in couple of sentences?
Ahmet, do you want to start first?
Yes, I have two patients I reoperated. That's because the sciatic nerve endometriosis, the reoperation is not an advisable and logical thing, especially for sciatic nerve endometriosis. But the patient's pain is very constant. Both of the patients very constant, and they cannot tolerate the pain. I really dissected this plane again. The first operation also, I made the first operation, but the plane is very intense and very difficult to dissect, and excise the endometriosis lesion is very difficult. I think do the best at the first operation. But sometimes you need to perform the second operation, but second operation is very challenging and very difficult. While performing the first operation, it is very important to complete or excise all of the sciatic nerve endometriosis cases. That's my opinion.
Best shot is best shot. Professor Usta, do you have anything to add?
So it's a very good question. I would like to share you one cases. Normally, when we perform the first surgery, we saw that there's some small implants on the hypogastric nerve, but at the same time, that lady have a sacral nerve roots endometriosis. We cut all lesions from the sacral nerve roots. Normally, some participants think that it is very difficult, but sacral nerves is very thick, and so it's not so difficult. When you know that structure, which is belong to nerves, which is belong to vessels, if you pay attention the bleeding, it is not so difficult. Sometimes, yes, you can face some bleeding, but when you talk about the supplanting nerve, it's not easy to diagnose that structures during the surgery because of the disease can attach that structures. And also, this is the same in hypogastric nerve. That lady have some disease on the hypogastric nerve. We preserve that nerve. When that lady passed 1 year, we see the pain symptoms come together and come again. And so we perform a second surgery about recurrence. We cannot say that recurrence. We left behind some small implants on the hypogastric nerve because the best approach is cut that nerve. But we preserve that nerve. We do not want to face a problem after that surgery, but we left behind some small implants. Then 1 year later, we face a recurrence of that disease. And so we performed the hypogastric nerve excision in that surgery. In that lady, that teach us if you see some lesions, and so the main problem is the pelvic pain, you have to do that one in a one-shot surgery fashion, like Ahmet underlined that philosophy. This is not only related with the deep endometrial surgery on the bowel. Bowel is not so easy, but it is the easiest one when we compare it with the nerve endometriosis. Especially sciatic nerve is a very difficult part because you cannot have a lot of opportunity to enter the iliolumbar fossa. You can enter that place one time. In some selected cases, if you need it, second time, but there's no time to enter that place third time. So if you do that job in a one-shot fashion, it's the best way. It's the very good way.
Yeah, I always remember Prof Passover saying that one shot is your first shot is your best shot. Right, well, thank you both very much. I think because of the time, we're gonna skip the two small articles, and we're probably gonna move to the second featured article. I'm not sure if Professor Olivier Donès is with us. Let's have a look.
No, Mikey, he is not with us.
He's not with us?
Yeah, I've emailed him.
Okay. That's absolutely,
I haven't heard back from him.
that's absolutely fine. So let's see if we can go maybe to a couple of Q&As, because we are pretty much on time at 7 o'clock. Glenn, do you want to go through the Q&As quickly?
Yes, let's see.
There's a comment from Ron: doing hysterectomy with coexisting bowel endometriosis can be associated with rectovaginal fistula, hence offering hysterectomy at the first place to avoid repeat surgery should be balanced against that. Yes, agree. There's a question from Sandesh Kader, just to confirm that the disease has proactively affected nerves and not necessarily the surgery. I'm not sure if I think that was meant for a previous discussion.
Yeah, it was about the paper from Prof. Kale.
I want to ask routine double J stents preparation insertion. There's a question about double J stenting for excision of endometriosis from Ryan. Simple question: do you guys stent for your deep endometriosis routinely?
If there is an ureter and hydronephrosis, yes. But if there is not, I don't use routinely WJ stent.
That question is related with the insertion of stent before the surgery. Before the surgery, that's maneuver getting difficult when you have a stent, because that ureter is some memory, and so when you want to make some movements, it's not easy if the ureter have a stent. After the surgery, yes, you can use it if you need it. It is routine approach, but before the surgery, it does not help your surgical dissection. It's making some difficulties during the dissection.
I agree. I agree. I come from Shaheen's school where we don't routinely stent. We stent only if there's hydronephrosis, or if we think that we're going to be artery implanting, or if we're reconstructing the bowel with a full thickness bladder nodule. There's a question about diagnosis of sciatic nerve root endometriosis, and I know you probably can both speak about it for hours in terms of the neuropelviological examinations. But there's a question from. I think it was, my question just disappeared somehow.
Sorry, the question was like about sciatic nerve involvement and how do you come up with the diagnosis? Is it based on examination findings? And how is the MRI used as a diagnostic tool?
First of all, we don't routinely ask MRI, first of all. The neuropelviologic examination is essential. After the neuropelviologic examination, we are with the neuropelviologic examination, we are mapping whether the lesion is the L5, S1, or S2 roots. And afterwards, and we are also looking at there is a foot troublesome, gait abnormalities, Trendelenburg Burke gait, etc. And afterwards, we are asking MRI. MRI is important, is valid for both cases, for both isolated sciatic nerve endometriosis and sacral nerve root endometriosis. And the second important issue is that the trained radiologist also is important. And also you must also inform the radiologist that I'm thinking and sciatic or sacral nerve endometriosis. Please look at carefully, and planning of the MRI is very important issue. And on T1 images, the sciatic nerve or sacral nerve endometriosis can be seen as a hyperintense locus, and T1 sequences, it might be an hypointense or hyperintense locus if there is a bleeding inside the endometriotic lesions. So MRI is a second line tools. First of all, the neuropathologic examination is important.
I completely agree with that. And one of the other things the other way of thinking about it is at least the way I think about it is, we are trying to diagnose the pathology of a nerve, right? We're trying to figure out where the pathology is on the nerve. Yes, I agree that MRI is a really good tool if we're dealing with endometriosis, but there's certain things like neurovascular compressions, for example, that might not necessarily be picked up on an MRI. That's why those examinations are really, really important, and they take a long time to do it. So hopefully this answers that question. There's two more questions. There's a question from an anonymous attendee asking about if a patient has a large endometrioma on the left side, is the likely sciatic endometriosis will be on the left? That will probably depend on the symptoms of the patient, right? And rather than on the endometrioma, but yes, we never know. And there's a question from Sandesh Kader, 89% needed significantly. I'm not sure if I understand that question. Do you guys understand that?
I think I wonder if Sandesh made a point about a comment that we did before, here.
I think it was about the comment. Ben, you can read the last question and then.
The last question is from Nilu Faragun. So he thanks for the presentation, a really good presentation. Thank you, Prof. Kali. And for reducing the size of a lesion, what do you advise? Do you advise the use of GnRH analog or antiprogestogens?
In the literature, there is no robust data whether the GnRH is much more efficient than the antiprogestins or progestins. If you look at the literatures, you can use both of them, and so you can try. You can first of all use GnRH, and afterwards you can use progestin therapy. But if both of them doesn't work, it means that if the pain persists, if there's some neurological disabilities or functional problems, for example, like foot drops or gait disturbances, it means that you must perform a surgery.
Mm-hmm.
So, but we cannot compare about on the light of current literature whether antiprogestins or GnRH is much more better. But you can try, and it depends on the surgeons or the clinician's experience and the person's symptoms, whether it works on some patients or some GnRH or progestins doesn't work for the other patients.
Okay, so Sandesh is he's came back to us and he said, I meant 89% of patients with sacral root endo needed colpectomy. So we are all clinicians can pick up per vaginal examination, and those patients will have a vaginal nodule. So in essence, he's saying that a large number of patients with sacral nerve roots endometriosis will have some sort of vaginal nodule. I think that you need to do vaginal examinations. To start with, actually, what is your view? Because in my practice, I can fairly easily pick up those big parametrial nodules. So you feel them. Okay, you can sort of on examination go as far as potentially as 2, as 3. Some people with longer fingers can even go higher. But what do you think of that comment?
Yes, the sacral nerve root endometriosis has, as you know, that is a part of parametric DA, different infiltrating endometriosis, and rectovaginal lesions or sacrouterine lesions or perivaginal or pararectal infiltrations is more likely can be seen. And yes, if there's we must or we should make a preoperatively vaginal examination whether there was a nodule or not. But the 89% is very high. In my review, I didn't find the same percentage. it is much more lower. But yes, during sacral nerve endometriosis, we also perform additional surgeries like colpectomy, etc. But the colpectomy is not very difficult or challenging surgery if we dissect the plane very precisely. For example, if we dissect the rectum from the vaginal part, and we can excise the vaginal nodule, but the 89% is very high. I don't really encounter this kind of percentage.
I do agree. It sounds quite high. On that note, I think it's 7:10. It's Saturday night. I think we all want to go get some food. So thank you very much, everyone, for joining us online today. Thank you, Professor Usta, Professor Kale. Thank you so much for joining us. Ben, Avril, thank you. I think Oscar's already gone. We're gonna do it again on the 6th of February at 6 p.m. same time. We're gonna have some Avril, who is gonna be presenting? I think Tom Holland, is that right?
Yes, that's correct. On diagnosis of superficial endometriosis on ultrasound scan.
So that's gonna be another interesting one. Thank you so much, everyone, and have a good night. Thank you.